Addiction isn't just a relationship with a drug. It's a relationship with yourself. You're not just a bunch of chemistry. You know, you're a bunch of your experiences and your traumas, and like that's the underpinning of like any of this stuff. And you have to know yourself. You have to have somebody who can guide you through it.
If someone has a problem with substance use disorder, please call One Call Placement. That's 888-831-1581. And if we can't help you, we'll make a referral to someone who can. One Call Placement is affiliated with Carrera Treatment, Wellness and Spa and One Method Treatment Centers.
Got Dr. Ben Shapiro and Dr. Brett Shurman here today. Why don't you guys do me a favor and we'll do a little character development for these folks. Why don't you start, Dr. Shurman?
Okay. I'm an adult psychiatrist, an addiction psychiatrist. I have a private practice, and I also practice at Los Encinas Hospital, both in the inpatient and the chemical dependency program there. And we have a new TMS company, Pacific Neuromodulation, for about a year.
That's fantastic. So what's TMS?
What is TMS?
Well, I know what it is, but tell the viewers what it is.
TMS is using...
First, tell them what it is.
Oh, transcranial magnetic stimulation is that's the name. It's using a powerful magnetic field to either stimulate or inhibit brain circuits. It's the simplest explanation.
And it's used for trauma.
It's used for numerous psychiatric and neurological applications. Yes, trauma is one of the things it's used for.
It's big with the veterans community.
It is, and getting bigger.
Yeah.
It's really effective for PTSD in our experience as well.
No, it's definitely,
it's amazing.
Yeah, it's amazing. Mm-hmm. How about you, Dr. Shapiro?
I'm Dr. Ben Shapiro. I'm also an addiction psychiatrist. I'm also a geriatric psychiatrist. I'm a little jack of all trades. I have a background in adolescent psychiatry. I also do a lot of work in eating disorders. So just an eating disorder specialty, and then do a lot of substance abuse stuff in general. So I work at a few different rehabs, one of including your own. I also do some work for UCLA.
With Dr. Fong, right?
Not directly. I do know Dr. Fong, though. Yeah, we go back. And Brett and I share ownership of this, our Pacific Neuromodulation, our TMS company. I'm the CMO.
Where is it?
There are 3 clinics, one we're buying. So there's one in Pasadena, there's one in Westlake, inside the Cure Clinic, in a Four Seasons hotel, and there's going to be one in West LA that we're purchasing hopefully in the next 3 months. And we also have
from that guy. What's that guy's name? It's the one on Olympic and Bundy, right?
Yeah. Yep.
What's his name again?
Stubman. Dr. Stubman.
Dr. Stubman. But he's going to stay on and run the stuff.
Not so much.
Why?
He's moving to Thailand. He's retiring.
Oh, you found a little Thai girlfriend?
No comment.
Oh, no comment.
Yeah, exactly.
That's awesome.
And maybe more than one.
Really?
Yeah. And we have mobile capacity as well. So we can bring the TMS to someone's home or a residential program, or, we actually did a case in Colorado. And there are new devices coming out that weigh a lot less, which we're grateful for, because these things are over 100 pounds. The cooling systems are very heavy.
How many people are you currently seeing a day in your TMS practice?
Well, we just, right now it would be 3, because we just started, about in March.
So, why TMS, guys? Why? Explain that to me. I want to do it even more. Tell me why.
Crazy effective,
especially starting about 5 years ago. I've referred to TMS, not been a TMS practitioner for like 25 years.
Mm-hmm.
It started out in 1985. It's interesting because the engineer who created it actually just gave it away. He had no patents, poor guy. So he made no money. He could have made billions. But in 2020 was the first.
The fact that he didn't do that, I hate to interrupt, but the fact that he didn't do that made the practice accessible. The science is always
15 years or so ahead of the practice.
Mhm.
But by him doing that, it shortened that.
Yeah, it helps humanity. I
It,
think.
it did.
Yeah.
It did. He actually gives talks now at TMS
Yeah.
conferences.
Well, he's got to now because he just gave away all his shit.
Exactly.
So he's got to look good. He's got to look good for it.
He's some kind of job.
Sweet guy.
Yeah.
So why TMS? TMS was always reasonably effective for depression. That's what everybody knows.
That's right.
But it still wasn't really much better than antidepressants for remission rates until 5 years ago. Stanford came out with an accelerated protocol. It's called the SAINT protocol, and they were getting remission rates in the 90 plus.
I'm sorry.
Stanford came out with a
For what rates?
For as in getting completely better remission rates.
So you're
Wellness.
So you're telling remission rates.
Yeah.
Is that relapse rates?
That's a different question.
Okay. So what the
Yeah.
hold on a second.
For that.
So what is a remission rate? That so someone's not depressed anymore?
It means they have no depressive symptoms. That's right.
Really?
Yeah, and they go into remission often in 2 to 3 days.
It always was effective at a reasonable remission rate up until 2020. And it was always non-invasive, no side effects, basically no risk. So if people were failing traditional treatment, therapy, or meds, I would refer to it. In fact, that insurance won't cover it unless it used to be 4 meds, now it's 2. So it has improved.
That's right.
Yeah. And it only covers.
It is the big limitation of insurance.
It is a limitation.
It's a limitation.
Yeah.
Because they don't want to have to pay for it right away.
Even if they don't want to have to pay for it, what's the most effective, and that's the biggest thing we run into.
Yes. So the most effective are these accelerated treatments where you can get somebody better. Potentially now there's a 1-day treatment. It's amazing. But there's 5 day. We do 1 day, 5 days, or 10 days. So in 2020, these protocols came out that were super powerful, and they actually got FDA approved in 2022. That's when I started getting very excited and very interested. And that's between that and a personal story I have. That's why I got into it. But it doesn't just apply to depression. It applies to 20 psychiatric disorders and neurology.
The
FDA has actually approved 6,
give me that.
and those are OCD, okay, anxious depression, anxiety, basically, depression, adolescent depression, migraine, pain, chronic nicotine dependence.
Yeah.
But it actually spreads to all addiction. There are studies now on many, many different substances, and as you know, there are no real medical treatments for many substances of abuse.
So tell me about that. How does TMS assist in the addiction treatment?
Take on.
It's just the basic protocols. There's different kinds of. If you talk about alcohol abuse, there's different reasons people drink. Some people drink to avoid withdrawal symptoms. Some people drink due to underlying anxiety or other things. Some people use it for reinforcement, and those are actually different brain networks. And it's still in development, but if you target those different brain networks, you can really focus on. You have the potential to focus on the reason for the addiction and have really kind of next level improvement.
Just so you know, anybody that is drinking to get well,
Right.
is started drinking, not to get well, but to quiet the mind.
Mm-hmm.
Absolutely, that other stuff, right? All right.
But I want to answer your question a little more specifically. So, there are certain circuits that affect impulsivity. There are certain circuits that affect reward. So depending on the clinical reason someone's doing drugs, it could be all of the above. You can hit all those circuits.
That's right. And it usually is. That's my point.
Mm-hmm.
Okay, because this is kind of like, you guys have the education,
Mm-hmm.
but I have. It's not just an opinion. It's 25 years of field research.
Right.
Right.
Right. Both using and getting sober. Right. So from the ground level, it's usually all of it.
Yeah.
So that's why all of the touch points need to be pushed, even if because otherwise what's going to happen is the human error aspect of it, right, is going to get in the way. You're going to miss a touch point. And it's not just, it's not just that they're vulnerable. They're not gliding through life, right? They're white knuckling a little bit because they're unsure. So they're spending all their time kissing God's ass. Please help me stay sober. Please help me stay sober. Please, right? And there's no thriving or growth in that.
Couldn't agree with you more.
Well, that's why you're here. Only the people that agree with me get to come on.
I'll try not to disagree, but I sometimes am disagreeable.
No, please be disagreeable. It's better ratings.
So there's an interesting dilemma / conflict within TMS, because most of the studies only look at one site. So multi-site protocols, which is what we favor for exactly the reason you said, are not well studied, and we're super excited about.
What about in Europe?
Even there, maybe they'll hit 2 sites.
Okay, so check this out. They're looking at each site individually, right?
Correct.
Okay, so who gives a shit? If they're looking at each site individually, collectively, they deal with the same thing.
That's our motto. That's why we do what we do. We hit multi-sites, and especially because at this point, the science doesn't support it's exactly this circuit. We're getting there, looking at the brain.
It's still hard to find what those are.
You're a year off, man. You're a year off with AI every 6 weeks.
It's coming.
Getting better.
That's why we're in this business.
Yeah. You're going to be able to tell. You're going to be able to do that. Exactly.
So the accelerated studies of depression are one site. But imagine using accelerated protocols in 5 sites. That's basically what we do.
Can you help erectile dysfunction?
Yes.
Asking for a friend.
With Viagra.
Asking for a friend.
Viagra,
I'm talking about TMS. I'm talking about without the pills, without the
No, but maybe ultrasound. Maybe. TMS is actually just hits cortical structures.
Yeah.
Both of you have decades of treating addiction.
Yes.
If you had to describe what the crisis looks like from inside your office, what are you seeing right now that the public has no idea about?
That is a painful question. Death. It's my, I pride myself that in my practice over 30 years, more or less, I have literally 2 suicides, and I treat very sick people. I should have 4 a year statistically, but I have so many fentanyl deaths. I've lost count. I don't want to count. So that's what we're seeing. Death, unintentional deaths. In fact, all of my deaths, none of them are suicide. They're accidental overdose or being unaware that there's fentanyl in whatever, Xanax the person bought. And that's just unbelievably, profoundly sad. I have at least 20.
Tell me about, and we're going to get to you in a minute because I want to ask the same exact question. But do you meet with the families afterwards?
Absolutely.
Talk about what it does to the families.
It rips them apart. I've gotten the most harrowing phone calls during one in particular. This kid was a rocket scientist, literally, and he had gotten sober, and he went back to school, and unfortunately there were parties, and all he took was some Vicodin and Xanax, but it was definitely laced with was in the autopsy report. And talking to that mom, first I talked to her when it happened because she found him in his room blue. He was still staying at home. And there were 400 people at his funeral because he was an outstanding human being. And she'll never be the same. It's unbelievable grief to lose a family member, particularly a child. It's unspeakable. That's my answer.
How about you,
Doug? As a doctor, what I'd add to that is it's unnerving. It's absolutely frightening to take care of a patient who's strung on is like Russian roulette, and you see them come in not really having the size of what they're doing and really having the danger. I had multiple patients that 3, 4 near death overdoses, and you try to explain them, they're just deaf. It's tough.
What's different about this? People were always dying of heroin, right?
Sure.
But the reason they died is because they overshot the mark.
Right.
And what most people don't know, and you guys can't explain it this way. Okay, you explain it in a way that gives people brain damage. Okay?
Mm-hmm.
But really what an intravenous heroin user is feeling, what feels the best for him is to get as close to death as humanly possible without actually dying. Now that sounds really scary, but that's the truth.
Mm-hmm.
But it's also the only way you could die when you are shooting heroin. Okay? Now, people are dying all over the place, and the kids that are dying are the straight A students, A, B student kids on the weekend, going to the concert, going to the party, going to the rave, right? and they're taking one pill or a half a pill and dropping dead within minutes. Okay. That's what's going on now. And the reason it's going on is because these kids have no tolerance for anything. So even a non-lethal dose to a user who's built the tolerance is killing these kids.
They don't even know they're using it sometimes.
That's the whole idea. They're buying something, they're bargaining for something, and they're getting something entirely different.
It was never safe to be a drug addict, but now it's like it's lethal in a moment.
It's not if, it's when you're going to die. It's not if.
I have no heroin overdose deaths in my practice.
The what?
I have no one who died from heroin because I deliver good care. But here's how I put it. It doesn't matter how much people love you. It doesn't matter how good your doctor is or how good the treatment is. You're going to die anyway. 20 deaths.
Today.
Yeah, now, currently.
If you're using it.
Yeah, for sure.
If you're using anything, I mean, even weed gets laced with it. It's crazy.
Do you guys remember at the AFC Championship game last year, they found those 4 kids face down in the snow?
Yeah.
From weed.
Yeah.
Okay, because it was laced with. If you're buying anything on the street right now or on an online pharmacy, okay, you're screwed. You're screwed.
Agreed.
Okay, you've got to get a script from a doctor. You got to get it from a brick and mortar pharmacy. Okay, and that's it. The end.
And so, therefore, when someone comes in and isn't dead yet, and you're treating them, the urge, I think, to get them better is much greater. And to prevent,
and that's why you like the TMS, because it's quick acting,
correct, and powerful,
and probably the Vivitrol, and
we use every tool available. This is just another tool that's super powerful and has no downside, and is very underutilized for multiple. Right. One is insurance, right?
Well, it's not going to get covered by insurance unless you jump through those hoops, which makes it really, really hard. But it's not just that. The machinery each machine is $100,000.
Yes.
And then what is it to maintain, like $20,000, $30,000 a year?
Yeah, that's about right, actually, because you have to change the magnet out. But also,
like that.
It's not well known.
I had no idea.
Yeah.
On my life.
Good guess.
No, but that's,
it is pretty accurate.
But that's the thing.
Yeah.
Right. That's why I want you guys to call me, because it's common sense. The math makes sense.
Also, the field, as a general principle, is terrible at what you're great at. They have not marketed themselves well. In fact, to the degree that the NIMH put out, National Institute of Mental Health put out 7 videos essentially marketing TMS to clinicians. And even when people do know, they only know about depression, and they often don't know about the new protocols. And so it's really underutilized, and it has so many applications, including addiction. But yes, it's not covered. The only thing that's covered is depression. So, how people get around it is it usually, if you have another disorder, including addiction, you have some depression. So they bill it as depression, which they have, and you treat the depression.
Well, they always have to. Nobody gets to treatment on a winning streak. I've never met I've never met anybody. Yay!
I don't know. I've seen your program, and I'm like, yeah.
No, that's after they've been there for an hour. After they've been there for a couple hours, they're like, oh, this is cool. Right. But nobody crosses the threshold like that.
No.
Yeah. All right, let's get in. Where do you see the line between psychiatric illness and addiction? Or is there no line anymore? Are we treating the same brain pathways?
Oh, they're definitely, addiction's a psychiatric illness, no question.
Same, so you're treating it the same way.
I mean,
it is an illness that we would view within psychiatry. Yeah, but
versus depression, anxiety,
but even those illnesses are complicated. Just like addiction, like they're not just brain circuits and chemistry. And
Can I tell you how I explain it?
Yeah, please do. Yeah,
it's all the same.
Yeah.
It all has to be treated the same.
Sure.
If you can't treat it the same, the roots don't take hold.
I mean, I agree, because I think that is a shift that has occurred within addiction medicine. It's like a good shift. Right. Because otherwise it's just AA, and AA is great, but there's
it's a support group. It's not.
Yeah. There's a whole bunch of other tools. Yeah.
That's right. Yep. That's right. We always did it that way from 2004. We've always done it that way because I didn't know any better. That's what things to me.
Yeah.
So if it fixed me and I was as bad as it got, I was doing, I don't even think they do drugs like this anymore. I was up 6 to 8 days at a time.
You have to know the reasons. You got to know the reasons why it's happening to some degree.
A lot of times you don't know the reasons, but yes, you have to understand that you've been lying to yourself all along.
Right.
Okay. And that it's all just been a bunch of bullshit. And then you have to show them along the arc where they've been lied to. A lot of times, I explain it like this all the time. A lot of times, people don't know why they're doing drugs and alcohol. They have no idea. And then you have to unpack it. And let me tell you what it usually is. It's usually, I'll give you something to cry about. What are you, stupid?
Yeah.
Right? And so you say to yourself as a 5-year-old, you're looking at yourself and you're going, your frontal cortex isn't developed enough to formulate the thought, oh, my parents are just idiots. You can't do that because you're too small, right?
Right.
And remember when you were small, everything was bigger. And if these people who brought you into the world don't love you, then you must be bad. And that's all you got at 5. I must be bad.
Totally.
And then it gets reinforced and reinforced and reinforced and reinforced. Pretty soon you got this 45-year-old guy being run by a 5-year-old mind, okay, that got reinforced all the time. And it's like the intervention is, hey, you see how this is horse shit, right? You see that this was a lie that is keeping you beaten down. It allows you to be a victim. And you guys would know as well, there's medication, there's all sorts of therapies to get you to realize what the truth is. Talk about truth. That is the truth that matters.
Agreed. A lot of it's trauma.
Did that make
perfect sense? Yeah.
Okay.
Totally agree with that.
Yeah.
Good.
And then you don't have the circuits to regulate your emotions or yourself. So you're going to find some way, some exogenous way. You're going to find drugs or alcohol because they make you feel better in the beginning.
They actually save your life in the beginning if you really have real issues.
Yeah. I always ask when I'm evaluating someone, I think Dr. Shapiro does too, why did you do this drug? Like, what was it doing for you in the beginning?
That's an excellent question. Do they know?
Sometimes they know, sometimes they don't. When they do know, it's very helpful.
But a lot of times, my guess is in this interview, in this assessment process, you've got a third of the people that don't know, maybe 10 or 15% that do, and everywhere in between, they're just horseshitting you, talking, trying to figure it out while they're telling you.
That is true too. But if they do know, it's very helpful.
Well, how do you know when they're not horseshitting you and they're, well, I guess you.
How do you know? Yeah,
how do I know?
It's clinical.
It's the only thing I know till the end. I mean, that's a lot of psychological you could go through the process of healing and recovery, and then sometimes the discovery is late, but it is important.
Absolutely.
Yeah,
absolutely. That's great.
For example, somebody says, I couldn't stop my mind racing. I couldn't sleep. I was,
So you told them to take a hit of pop.
Exactly. And so, and that slowed me down. Okay. Now I'm thinking ADHD, bipolar, some kind of impulse disorder. That helps me as a doctor.
Do any testing?
I do testing when I'm confused, when I can't figure out, what's going on at all.
Aren't there certain diagnoses that replicate each other? One that comes up to mind with me is bipolar and borderline personality disorder. Like they kind of touch each other. One's like, I love you, I hate you, I love you, I hate you. And the other is, I'm so depressed that last few days, and you pull out of it, and then you're manic for a couple of days. And the only time you get here is when you're blown by it.
The time course helps differentiate those things, but they do overlap. And in fact, this guy, Dr. Akiskal, a famous professor at UCSD, used to think borderline was a subtype. I think he might have passed away, but he said it was a subtype of bipolar and should be treated as such.
So do I.
And used as use mood stabilizers. So
it's not that way it is anymore.
Borderline is much more about detachment issues that you're talking about. All that disruption, early disruption versus where there's a set of
But if that was true, then I'd have borderline personality disorder, and I don't.
It's not. It doesn't. It's a lot more complicated than that. But the things that trigger all those changes, those mood changes, have a lot to do with relationships more than just sort of like an internal rhythm.
I'll give you an example of the complication of talking.
Please.
I'll use my wife's family. Okay.
Good.
So
Do we really want to do that?
you can cut it.
No. I mean, is she going to be pissed?
No, I don't think she will be.
Okay, you don't think she will be?
She will not be.
Okay, good. I mean, you're not, as long as you're not sleeping in the guest room.
I'm not going to use names.
All right.
So they had a very large trauma when they were little. It's like an epic Chinese opera. And their father was assassinated in Taiwan. He was a minister in the government, taken from their home, which two of them actually witnessed. My wife was actually 1 year old, doesn't remember any of this. Okay. So that was a big, big trauma, had to move to the U.S., no money, et cetera, et cetera. Okay. Of the three of them, the middle one had a lot of depression from the time she was little. My mother-in-law.
How old was she when she saw it?
She was probably 6.
There it is.
So, but the oldest one, okay, was 9. So, but the middle one had depression from the time that after this happened. And my mother-in-law moved to the U.S., kind of got a substitute, husband, not a real husband for economic reasons. And he wasn't a great guy. He wasn't abusive, but he just was sort of a nebbish, and the way these 3 girls interpreted him was so different because the middle one's mood was depressed all the time. And so she interpreted him very, very negatively. Like little things he would do, complain about money, would become, she would go to bed, the father, this is a stepfather. Okay. She would go to bed hoping he would die or she would die. My wife would be like, whatever.
The father was taken and killed.
The biological father was killed.
And so now
this is in the U.S.
So now the stepfather, the little one, wants him dead.
The middle one. Okay. Little one's my wife. And the middle one and the older one, functioned fine basically in life. They had problems because there was trauma, right? But the middle one became a borderline. And the point I'm trying to make is when you have that chronic mood problem from a young age, that also affects your development, your attachment, your psychological profile. This is what I'm saying about it being complicated.
Right.
So
because when you start off that way, you're limited and
you interpret reality differently.
And your growth is also limited.
And so she never functioned well, and she's doing better. We got
That's
some.
so heartbreaking, man.
Yeah, it's terrible.
Do you know what I want to just get off topic for a second? You're talking about that story, and I feel myself welling up. I feel like I'm getting re-injured every time I do a podcast.
Yeah.
Every time I talk to a client, because I've been doing it so long, it re-injures myself all the time. Okay. How are you guys not injured the way I am over something like this?
There's something about it that reminds you about your own narrative.
No, it's just, no, I'm heartbroken for children. See, when you're as old as, when you have children as old as I was, after losing a quarter of a century to drug addiction, you don't think you're going to have children. You thought you missed it. And then when you get it, you're so grateful for it. You don't just love your children, you love all children.
Well, there you go. We do hurt. I mean, we do feel pain. My answer is I ride on my Peloton really hard, after a day, and the pain varies depending on, I think he does have a point. If a story really resonates with your own experience, that's going to, of course, even more pain, right? Much. But I'd rather have that pain and help people than not have it,
But how do you I'm viscerally affected. You guys are not. It doesn't appear that way.
No, well, we're kind of used to that. But we're not talking. It's not. You don't have a relationship with the patient. When you have a relationship with the patient and real things.
Do you have children?
I do have a child.
How old are your children?
11.
Okay.
Yeah.
You've got an 11-year-old. So 5 years ago, that child was 6. So you don't do what I did. I've got a 12-year-old. Automatically, I take the 12-year-old, I put him back to the 6-year-old, and I say, oh my God. Okay. But it's not just for my personal experience.
Right.
It's for yours.
Yeah.
And yours.
Yeah. I think also we have our training, for better or for worse, does teach you to detach.
Right? Detach, but
But when you're caring for somebody, you have a relationship with them. I mean, there's a lot, you go through a lot.
Can you give somebody the same or better care when you actually care about them?
I think
than when you're
1,000%. Actually, there's science
Super
for it.
important. Yeah.
Give it to me.
Well, if you look across therapies, different kinds of therapies, you would think it would matter which kind of therapy, and it does matter some. But the biggest variable that predicts outcome in any therapeutic experience is the relationship with the patient, the level of empathy the patient feels from the therapist. And it's true for psychiatrists too.
That's
Even to the point where if you don't have a good relationship with the patient, it's not really, I argue it's not responsible to take care of them because it can be,
I got that too. But what you just said was how the patient feels about you, the therapeutic alliance between the patient and you.
Right.
I'm talking about whether or not let me say it a different way. You've got a friend who's got a child who's struggling, but you love your friend. So you love your friend's child.
For sure.
And you're going to do whatever you can to make certain. Then another random guy comes and he introduces you to his kid, and you're going to help this kid because this is what you do. Who gets the better treatment?
Well, I think the thing is when you're in treatment with somebody over time, just like anybody, and it's a good treatment, you connect with them more and more and more. And you cannot deliver good care without caring. So occasionally you'll get a patient, you just don't connect. And I have referred people out, like we're just not a good match.
That doesn't mean there's not like turbulence, but you have to resolve it.
Let me tell you one other thing on the subject that I think you'll like, because this isn't just related to therapy. So I believe it was a UCLA psychologist, who did a study that looked at the relationship between a psychiatrist and a patient. It was a big drug study that already existed, right? So we're like 8 psychiatrists, drug versus placebo, nothing to do with therapy. And the question she asked is, do individual psychiatrists get better outcomes just with medication or therapy? And the answer was yes, 25% better. The ones where the patients rated them as more connected had 25% better outcomes.
Definitely.
With
okay, but they had better outcomes with you because they trusted you, and they're still talking to you at least once a month.
They get better.
Yeah.
For an hour.
Yeah. Absolutely.
Right.
Yeah.
So it's
still a relationship.
So it's even med.
Yeah.
But I don't think that would be the case with just straight meds without having a conversation.
Still have a relationship.
You guys.
But that's the point.
Yeah.
Because even meds work better if your relationship is good.
That's right.
That's the point.
Right.
The two.
Yeah.
Yes.
There is no, I'd say there is no medication management appointment because there's always a therapeutic element to it. There's always a relationship. As
But there are, here's the thing. Do you know who I love, who my favorite psychiatrist is? Danny Siegel.
Know him well.
Okay. You do?
Yeah.
He just wrote a blurb for my book.
Yeah.
And I cried.
It's a good writer.
It's not even that. It's like, it just says you're legitimate. It's a validation. And you see this? This is 25 years of crack.
Right.
Right? This is like, I remember I owned my last place and I couldn't write a check for bread and eggs and the market because I was in check systems for 10 years.
Wow.
And I had like 5 houses.
Yeah.
Right? It's like you feel a certain fraudulentness.
Yeah.
And then you have, the ambassador to the European Union in your house doing a podcast, or you have a great like Danny Siegel, right? Or you have a great like Dr. Amen that wants to come on your podcast and have you on his, right? It's like, dude, that's not supposed to happen to people like me. But you guys get it because you take people like me all the time, and you can be a testimony to the fact that we're the only group of people where you can find us in a dumpster. And 7 years later, you're the district attorney.
Have stories like that. It's amazing.
Damn straight. All right, let's move on. All right. How often are people misdiagnosed, given antidepressants or stimulants, when what they really need is addiction treatment?
You take that.
But how often do they hide their addiction? All the time, if that's what we're talking about. I'd say
No. What I think what the question was to me was, how often do psychiatrists misdiagnose a client or a patient, okay, when they really should have just gone to a top-notch treatment facility?
I don't know about the percentages, but I'm just going to say high.
Yeah.
I get people all the time inappropriately on numerous medications, certainly addictive ones, benzos, stimulants, opiates, who often hid their addiction or, don't really even realize they have addiction. You have to be really careful.
If you put somebody on Adderall without the psych testing, you're a scumbag. Okay. I mean, I've seen, please.
I mean, that's a strong statement, but
all my statements are strong
Yeah.
statements. But I'm not married to any of them.
If I have any doubt, I get psych testing.
That's right.
Because it's so easy now with the internet and chat GBT. Let me just look up all the symptoms of ADHD and tell this doctor. You see it all the time.
Right.
And then, they're snorting Adderall, 5 minutes later.
That's right.
So I want objective proof that you actually have an attention problem. And the only way to get that is testing, to your point.
Right.
And otherwise, we're doing a subjective assessment, which is easy to fake.
That's right. No, because drug addicts never lie. So that's
Never.
All right. We're through this thing. When families bring their loved ones to you, what's the one thing you wish they understood about addiction that almost none of them do?
That it's a disease that kind of takes over your will. I think that they don't realize like how profound it is, how deep and how it just controls their life, and how important like really strict boundaries are, and really serious limits.
I agree with that. It's a paradox for families, because in a normal family system, somebody's having a problem, you help them out, give them some money, get them an apartment, whatever. And with addiction, it's kind of the opposite. Not that you don't help them out, but you set very strict limits. Like, I can't help you unless you go to treatment. That's the hardest thing. They often don't get that for a while. It's a process to get them to that point. And since the patient has no will, right, someone's going to have to exert some will.
Yeah, patient. Yeah.
That was totally way too empowered all the time.
That was the most beautiful answer I've heard in a long time.
Yeah.
Truthfully, because you're exactly right. You're exactly right. That's exactly how it works. Wow. I love that. And you know what I love most about it? Plain spoken.
Trying to take notes from you.
No. Really. You both trained in the golden age of psychiatry, but now you're working with cutting edge tools like neuromodulation and you're doing mushrooms?
Oh, I do some psilocybin research.
Psilocybin.
Yeah.
Okay. What do you trust more, classic psychotherapy or these new frontiers? And I didn't mean to throw water on it. Hey, listen, I've got a blank canvas, man. I'll give you my thoughts on that, but I want to hear yours.
Well, it's not an either or issue. I mean, like I'm interested in patients doing better. Like, I'm committed to like their well-being. I'm a patient's doctor. Like, I care about my patients. I want them to do well, and I use whatever tools are necessary. So, and usually you combine them. I mean, that's one of the amazing things with TMS is there's like, we're kind of pushing this agenda to really involve aspects of therapy, because when you go through TMS, you have these periods where you're much more receptive and you can grow more from humans. Our company pushes it, and you won't see that in other TMS clinics. They just stay in their lane and give you TMS.
Right.
We will listen. You need to exercise, eat well, get CBT for your OCD or whatever it is, and it's especially important you do that in the next 2 weeks, in the next 2 months, because your brain's going to be better at these things. It's synergistic. So, but to answer your question, I mean, I think there's promise in psychedelics, but that's what it is, promise. It is not here. And what I've seen, and you have to be very careful. You're careful with addicts, bipolar patients, schizophrenia, because you can really mess them up.
Tell the audience about ibogaine. Do you guys know anything about ibogaine?
I have some experience, limited experience, only a couple of patients.
Give it to me. What does it do first?
Honestly, I couldn't answer that question.
Ibogaine is it has a lot of dangers associated with it because it can really, it has a lot of cardiac risks. And so that's one of the big issues with that people don't always understand. I mean, there's a lot of cases of people dying from it.
I don't know as much as I should know about it, but I'm going to know everything about it because I made a decision the other day to try all these new things because I'm in transcendence. I don't care. I couldn't wreck myself with drugs and alcohol if my life depended on it now. It's just, you can't treat this many people, okay, and do what I've done and still suffer from that particular thing. It just doesn't make sense to me. So I want to try all of this stuff. Now, I did the toad poison, and that's complete horseshit.
Yes. I've had a bunch of patients do that. My experience of ibogaine isn't all that different than other dissociatives or hallucinogens. Like they're very effective short term. I think the long term is a question. And what I've seen is if that's all you did, whether it was a psilocybin trip, MDMA, ibogaine, and you did no other therapy after that, yeah, you're good for 2 months.
Can you get MDMA from a doctor?
No, but there are.
How do you know that there doesn't have fentanyl in it?
I mean, good question. I don't recommend these things, but my patients find practitioners, and some of them are actually pretty good. And what you can see is an amazing transformation in mood or trauma. But then if they don't follow that up, with therapy, they
just revert.
Even ketamine, which is regulated and licensed, it's the same problem.
Yeah, they just don't last.
They don't last.
Can I tell you what my feeling is on? And I've never done ketamine, so I don't know. And I hate trying that. Man, the drugs are so stupid today. Jesus. All right. But my take on this is, truthfully, for the people that have never dropped acid or taken mushrooms, okay, and then in their adulthood, they trip once. Of course, you see God, idiot. That's my take on it. But that's my take. That's my take prior. That's my contemptual take prior to investigation. Okay. So I sound like I'm no different than an old timer screaming, "Get off my lawn."
Yeah, but there's a thing that happens with psychedelics. To add to that, they also the reason they're therapeutic is they also see themselves in a way without, like, they can see the trauma, the experience, their ego disconnects from it. They can see it without the pain, and that's therapeutic, but it does not necessarily last. And that's the problem.
It's a beginning at best.
I think that's something that you're so smart that you're hoping they see, but that they have no idea that that's what they saw. And the only way to get them to see it is afterwards to kind of guide them into what they actually saw.
Yeah, no, I mean, there's a whole school of psychedelic assisted psychotherapy, and that's what you do. I mean, you kind of guide them and you work with them, but
like a shot.
Yeah, exactly. But you got to do. It's without that structure around it. It's not.
No, it's bullshit.
And we like science because we're nerds, and because it's truth that matters. And so there just isn't the science in terms of long-term treatment, and they're working on it. And so when it comes out where we can know that we don't even know dosing for these, how much do you give? So people are doing it. These cowboys are doing it, and they're doing it by empirical guessing. And there are some good ones. I've seen some amazing beginnings. I've seen people see stuff, and forgive themselves in that experience. And then if they continue, it's a great beginning.
That's right.
But if they don't, it just goes away.
Most ketamine patients I have, they return back within 3 to 6 months.
Whether we're talking about mood or trauma, actually, because they use ketamine for depression too, and
That's right.
It's fast, but it doesn't.
That's why we like TMS, because it's different.
Which, by the way, if you're going to do TMS and it's so effective, okay, how are you going to make money?
We're going to talk to you.
No. My point is that
Los Angeles,
there's not going to be. I mean, seriously, guys, it's not like you're buying toilet paper where you always need toilet paper. It's not like you're buying Advil where it's more like the treatment that we provide.
It is,
right? And so you and I know for me, we're only marketing to like 1 million people in the country out of 335 million people. So at a certain point that ends, how you're going to treat it. Well, I guess
Theoretically, you could market internationally, right? Because if they're getting a cash pay accelerated protocol, you don't have to deal with insurance.
that's right.
I'm talking big, but we don't do this yet. But you theoretically, I know that the colleague, Dr. Stubman, has had people come from China,
Oh yeah.
other countries. So there is 3.5 billion or whatever, or 8 billion, to market to.
I love him on the podcast.
Yeah, you want it. It'll be pretty tough.
Yeah,
He's on his way out to Thailand. Like,
he's a diehard academic, but
yeah, he will not make it simple. That's
Yeah.
for sure.
but just to kind of go back to your, even with TMS, you still see, relapses, symptoms come back. And it's not a permanent treatment. It can be durable though. It can be pretty good.
Yeah, it's about
And it depends on the person.
it depends on the person and what else they do, right? With that,
And there's lots of things we can do.
it's about
Yeah.
best data, 50 to 60% of people with just depression will be well a year later.
Doctors prescribe opioids, benzos, and stimulants, sometimes recklessly. From the inside, do you consider this medical malpractice or just the system failing?
It depends, I think.
It's a bit of the system failing. There's the problem is there's a range of opinions. And there's like a range of practices going back to 5-10 years, and some things that people do I don't think are reasonable at all. So I think it's a systems issue in part.
I do think most doctors are well intentioned.
Yeah.
I do.
But yeah, it's a system problem. It's sometimes they don't do a thorough evaluation. They don't have any. Listen, when we both trained at UCLA, okay, 1994 to 98 for me, there was one addiction rotation in the VA, inpatient. That there was no addiction fellowship that Tim Fong runs. Didn't exist. So you got a whole generation of psychiatrists that know nothing. They have no idea that probably 30% or more of what walks in their door has a substance abuse problem.
Do you know why that is?
Please inform. No, it was terrible. But
Because in medical school, you get 1 week of addiction
exactly,
treatment experience.
that's my point. Yeah,
1 week.
yeah.
It's
The
a
reason,
Which is why it's so insane. And not you guys, because
Yeah.
you guys are in addiction.
Yeah.
But when I have another doctor who's not in addiction
Yeah.
talk to me about addiction,
yeah.
I just like shut him the up now,
So I got
because you don't know anything.
I got very little training, but I realized over time, like, oh my God, I better know something about this. This keeps coming up,
That's right.
and so
Well, now you're an addiction psychiatrist.
correct. I got the training, and
You know how many of you there are?
not a ton.
1,500 in the
Yeah, I was
country.
going to say 2,000. Yeah,
1,500 addiction psychiatrists
Yeah.
in the country.
that's absurd.
It's absurd.
Yeah.
And do you know who the president-elect is?
Oh, Dana.
No.
No.
Gana's not the president-elect.
Oh,
Is she the president now?
No, I thought she was on the Maybach.
No, the president-elect,
yeah.
Dr. Fong.
Oh, I did know that actually.
Isn't that cool?
Yeah, actually, I came up in your podcast with him.
Yeah.
Yeah,
Fancy,
yeah.
he
That's
said.
great.
You better cut that number.
Yeah,
I love him. Yeah.
Yeah.
I thought
Yeah, he's great.
he was great.
Wasn't he great? You watched the
I mean,
podcast?
I did.
Yeah.
He's fantastic, isn't he?
Preparation.
Yeah.
Uh-huh.
I thought
Don't
he-
worry, I jerked him around too, like this the whole time, just to
I
make.
have to think about.
I thought he handled your, provocations pretty well, actually.
No, the ones that he didn't handle well,
You cut.
we cut. Yeah, for sure, because I want everybody to look like a king here. All right.
Thank you.
Carrera was built around therapy first.
Yep.
Not a 12-step clone for sure.
Mhm.
Okay. From your perspective as psychiatrist, why is this approach different and why does it work for the kind of clients who come here?
I mean, people are addiction isn't just a relationship with a drug. It's a relationship with yourself that comes first, like some kind of early trauma.
Stop. That was gorgeous. That was so good. Go on. I'm sorry I interrupted you, but it was too good.
Like it doesn't. It's you're not just a bunch of chemistry. You're a bunch of your experiences and your traumas, and like that's the underpinning of like any of those problems. And you have to know yourself. You have to have somebody who can guide you through it, shepherd you through it.
Those are your glasses, man. That's what you're looking through, your life experiences and your traumas and your just the whole thing. And that's the only thing, it's funny. If I was walking around blind forever and I had my first sponsor in AA and we're driving in my Jeep And I'm literally getting out of the car to look at where we're supposed to be, getting back in the car and going, looking at the street sign.
Mhm.
And he goes, dude, you're blind. You need to get your eyes checked. I'm like, no, I don't. Right?
Right.
I went to the doctor for his direction, the optometrist, and he said to me, how long have you been walking around blind? Now, if that's how you see and you don't have anything to compare it to, how the hell do you know you're blind?
Right.
Same thing, right?
Great metaphor.
It is.
What's a metaphor?
You
I'm just kidding. John, my fault.
we cut that.
No, that stays.
Yeah, you got me. I was like going to explain what a metaphor was,
I know.
which is ludicrous.
You don't think much of me, do you?
No, I think you know what a metaphor is.
All right, go on.
And any, just answer questions.
I know, baby. You're
Therapy is also individually specific. AA is a beautiful, community.
support group.
It's a structure.
It's a sport. I mean, I think principles actually overlap with a bunch of different therapeutic principles, but
Absolutely.
it is not specific to you and your problems.
It is not.
That's the difference.
That's right.
You need both. Ideally, you will.
We need,
both.
look, we need community.
Yeah.
Okay. But you can find community anywhere.
Yeah. The other thing though is, drugs become, they end up becoming a sense of meaning for the person, and that has to be replaced. What I'm trying to explain is that when you're addicted to a substance, that substance, it's not just an addiction, it's sort of a belief. It's like an attachment to it. And you need to have, you need to kind of understand, you need to restructure that so that you have your other elements of your life bring meaning out. And so you replace it.
That's beautiful. You replace what you held as most valuable with something of equal or greater value.
Absolutely.
And it shouldn't be there to begin with.
Which is hard to do, but if you don't do it, you aren't getting clean, in my opinion.
Right.
I know somebody who says that all the time. Okay. If you could speak directly to a 16-year-old who's about to try for the first time, what would you tell him?
Don't do that. You're going to die. I would say,
What are you trying to get out of it?
Yeah.
What are you trying to get out of it?
Yeah.
Let's role play that.
Right.
I'm depressed.
Yeah, that's not going to help.
But you don't understand. I go to school every day and these girls just talk badly about me all day long. They just won't stop. They're bullying me online. Okay? I can't take it. I have no friends. I'm laughed at.
That's horrible. I'm so sorry to hear that. But that's not going to solve it. We got to find another way.
I don't know another way.
Well, that's why you're here. That's where I'm at.
Well, you're not giving me any hope. What other way? Because right now, the only thing I want to do, okay, is check out because I'm miserable. What do you got for me, doctor?
I got a solution, but it's going to take some time. And we have to kind of spend some time together understanding what that is and what really understanding your how you're really feeling and how else we can.
I feel like I want to kill myself, but I'm not going to, so you don't have to 5150 me. I'm not contemplating anything. It's just, that's the overwhelming thought that I have. I just don't have the desire or the courage.
But a piece of you brought yourself here today, right?
Yeah, my mother.
Yeah. Yeah, but isn't there somewhere in there a piece of you that wants to still live?
There's the piece of me that doesn't want my mother to go through any pain.
So you care about her.
I love my mother.
Okay. Well, that's an important part of it. That's part of your part that brought you in here, your love for her. And we got to work with that.
Okay. So you would leverage her with the love of her family.
I leverage his love for his mother, not so much her. Maybe her.
Oh, I was a woman. The guy that I was talking to. Okay. Yeah.
Yes.
All right. That was beautiful.
Yeah. Find some kind of anchor because there's usually at least something.
Yeah.
All right. Hey, did I leave anything unsaid? You guys want to talk about anything? You guys need to say anything? Did you get done what you wanted to get done here? Do you look good? Did you have any books to promote anything?
Books about addiction or books about TMS?
That you wrote?
Not yet. Working on it.
There's a dating service.
Yeah.
You got a dating service?
Everyone tells me, the app, he's talking about the dating app idea. Everyone tells me to write a book, but I've been busy treating patients for 30 plus years.
Right. Cool. Well, then you got to find somebody to write it with, another doctor to write it with.
He's an excellent writer, actually.
Do you have a book?
Not a recent one. It's a little dry.
Okay. It's a little dry.
What a shocker.
I actually cite a chapter in Ibogaine for some time ago.
But you wrote a chapter on Ibogaine?
Yeah, for like a Andrew Weil book. Yeah. With
That's fantastic.
yeah.
See you next Tuesday.
And they're good doctors too.
We're out of time. Please subscribe on YouTube, click the thumbs up, and leave a comment. Please subscribe on Apple Podcast and Spotify and leave a rating and a review. And share the We're Out of Time podcast with others you know who will get value out of it. See you next Tuesday.